to one and all. I extend a hearty welcome to all of you to the online teaching program for postgraduates in pathology. Today, that is June 14, we have a talk by Dr. Anita Borges. Ma'am needs no introduction. She's the lab director and consultant pathologist, Center for Oncopathology, Mumbai. And today, ma'am will be talking on an approach to encapsulated lesions of the thyroid. The moderators for today are myself, Dr. Bushra Siddiqui. I'm Assistant Professor, Department of Pathology, Jawaharlal Nehru Medical College, AMU Aligarh. And my co-moderator is Dr. Sayyeda Muniza, Assistant Professor, Department of Pathology, Government Medical College and Hospital, Aurangabad. The webinar hosts are Dr. Anita Borges and Dr. Sumit Gujral. Before we begin with the talk, a few important reminders. In case of connection interruption, low or no sound, video freezing or video lag, kindly leave the meeting and rejoin with the same link. If the problem persists, kindly check your internet connection. Please answer the questions by typing in the chat box, and please do not send requests for annotations to the presenters. That is, kindly do not click on this icon present on your screens. A few disclaimers. A few more disclaimers. Coming Thursday, that is June 16th, we have a slide seminar on head and neck and thyroid cytology by Dr. Mufaddal Moonim, consultant histopathologist, Charing Cross Hospital, London, UK. That will be followed by a lecture on approach to hemolytic anemias by Dr. Prashant Sharma from Postgraduate Institute of Medical Education and Research, Chandigarh, on 21st of June. So without much ado, let's invite Dr. Anita Borges to start the talk and teach us about an approach to the encapsulated lesions of the thyroid. Welcome, ma'am. Over to you.
Thank you, Bushra. Thank you, Muniza. And as usual, thank you very much, Ruchi, who's, oh dear, what happened to my sharing of the screen?
Yeah.
Can you see my screen?
Yes, ma'am, it's visible.
Yes, ma'am.
Okay, let me make it full screen. Okay. All right. I've done this talk not once, but many times before, not necessarily during this online teaching program, because there has been a constant change in the way that follicular patterned lesions are have been dealt with, both in our everyday clinics as well as with the WHO. The WHO has taken very different stands on encapsulated follicular pattern lesions. And I think if you have to understand what is going to come out now as WHO 2022, it would be worthwhile going through the historical evolution of these encapsulated follicular pattern lesions as to what we have been calling them. And of course, I'm not going back to Baba Adam ka Jamana, because I can go back to that. I'm old enough to remember what we used to do in the 70s and 80s, 1970s and 80s. But let's start with something around 2004. And the reason why a historical perspective is important is because there is one simple problem. If you don't remember what the past is, then you are often doomed to repeat the same mistakes as have been made in the past. So if we get this historical perspective, I think we will be sort of better off in many ways. Yeah. So let's go now to the classification of thyroid carcinoma as it was in 2004. This is a very simplified version. Of course, it was much longer than this. There were many subtypes and so on. But I think what we are going to discuss today is the tumors of follicular epithelium. You know that the thyroid has got thyroid follicles and it has got C cells. Okay, so I'm not going to talk about the C cells because all our follicular patterned lesions are tumors of follicular epithelium. And there is a little bit of a sometimes confusion, particularly in the minds of younger people. What is this follicles that we are talking about? Now, we use the same term follicle when we want to talk about derivation. So in one instance, we're talking about tumors of follicular epithelium, as you see over here, versus tumors of C cell derivation. Okay. On the other hand, you see another word follicular over here in this oval that I have demarcated, and that is about a pattern. So we have to distinguish follicular when it is used as arising from or differentiating towards the cell that forms the lining epithelium of the thyroid follicles, and these are the cells that make your all your thyroid hormones as well as thyroglobulin. Yes. Now those cells under conditions of neoplasia can look follicular, in which they resemble the follicles of the thyroid, or they can be papillary. They may be both papillary and follicular. We'll see what those kind of tumors have been called. And these are the ones where you can actually distinguish a pattern, and we call them differentiated tumors, tumors of follicular epithelium that are differentiated. But there are poorly differentiated tumors, and there are completely undifferentiated tumors, all arising from that epithelium which lines the follicles. Okay, so now that we have, I think, if there's anybody who has any problems about this, of course, I can address it in the chat box. Okay. So now let me start with papillary carcinoma. Okay. This is how the definition in 2004 was actually derived. So in 2000 WHO 2004, it was the papillary carcinoma that was defined. And this is important. Remember, it was not the follicular carcinoma that was, or follicular neoplasms or adenomas that were defined. It was everything from the follicular epithelium that was differentiated was first defined as papillary carcinoma, and everything else then was follicular in nature. Okay, so what is this papillary carcinoma? It is a malignant epithelial tumor showing evidence of follicular epithelial differentiation. And by now, I think you understand what that follicular epithelial differentiation is. This is not of C cell derivation. Okay, good. Typically with papillary and or follicular structures, as well as typical nuclear features. And I've shown you the nuclear features on the right. And I think all students, that's the first thing that everybody comes to know when you're looking at any thyroid tumor, is that you are trained to identify the nuclear features of papillary thyroid carcinoma, NFPT, okay? And what are those typical nuclear features? Ground glass appearance, orphan Annie, I'm sure you know about orphan Annie nuclei, large pale vesicular nuclei with grooves, pseudo-inclusions, okay? But the main thing was that there were no papillary adenomas, and up to now, we don't have anything in the thyroid that we call a papillary adenoma. Okay, now that is a very curious situation, which I don't think you find anywhere else in the body, but every system has got its idiosyncrasies and peculiarities, and this is the one for the thyroid. All right, now that we have defined a papillary carcinoma, you have to understand that, this was so curious that, even somebody like Juan Rosai, and I think this was a tongue-in-cheek article that was written, and you can read that. He said, and this was in 2008, which was similar to what we were doing in 2004. In fact, it was similar to what we were doing in the previous classification of thyroid carcinomas. He said, at present, a thyroid tumor can have papillary, follicular, solid, trabecular, or cribriform patterns of growth. It can be composed of large, small, oncocytic, clear, round, spindle, columnar cells. It can be encapsulated, minimally invasive, or widely invasive. In some, it can have any of these features, but as long as it has PTC type nuclei, it is thought to be, he has very cleverly used the word thought to be, a papillary thyroid carcinoma or one of its innumerable variants. And you can go and look up the 2004 classification. There are so many subtypes of papillary thyroid carcinoma. And this was really curious. And what he was questioning over here is whether the nuclear features of any tumor can be used to make a firm diagnosis of one kind of cancer. Okay, so this was his contention in this particular article, but this was the definition of a papillary carcinoma, and it went on to be the definition of papillary carcinoma and is still to some extent the definition of a papillary carcinoma of the thyroid. So this is why I think we need to have some historical perspective when we come to the new classifications of thyroid carcinoma. All right, having dealt with papillary thyroid carcinoma, let's come to tumors that are derived from the follicular epithelium, and we discussed that, but which have a follicular appearance. They all form follicles, little round structures, as you see here on the right-hand side. And here, how is it defined? Just look at the definition. It is a well-differentiated neoplasm of thyroid follicular epithelium that is not a papillary carcinoma. So here, there is no positive definition. It is a definition by exclusion. Now, that itself is another very odd sort of way of defining a tumor, but that was what it was. It was in the WHO 2004, and let me tell you, for all practical purposes, it is still a way in which we make this diagnosis of differentiated neoplasms which have a follicular appearance. So, follicular neoplasms, once you had decided that these were not papillary tumors, they were either called adenomas or carcinomas. On the right-hand side, you can see here is a follicular well encapsulated lesion, which is not showing you any of the features that you expect in a carcinoma. And like anywhere else in the body, a carcinoma is by definition something that is invasive or metastatic or has metastatic potential. Every invasive lesion is not malignant, but to be malignant, you must have an invasive component. Okay, so then what is a follicular carcinoma? It has to have invasion. That is what is the definition of a carcinoma. And this is this follicular carcinoma. In 2004, we had a minimally invasive carcinoma that had all the features of an adenoma, which means it had a capsule, and that capsule was invaded, as you see on the left-hand side here of this, the left-hand side illustration. Necrosis was by definition absent, or it was widely invasive. Of course, it could invade it could invade a blood vessel, which is angioinvasion. We'll define all this. And the widely invasive were all other unencapsulated follicular neoplasms. Now, I want to say something over here. There is a widely held belief that all follicular carcinomas start out life as being follicular adenomas, then they invade their capsule or they invade the blood vessels, and then they invade the rest of the lobe of the thyroid gland. Now, that is not true. You can have a follicular carcinoma that never started off life as an adenoma. Okay, it is just sheets of invasive carcinoma cells, and they are not poorly differentiated. Okay, so I think that we have to understand that there can be follicular tumors that start out life without being encapsulated. So you can come across a widely invasive follicular carcinoma which has no capsule. Anyway, that's not the subject of my talk today. So now it became, if you had an encapsulated follicular patterned neoplasm, and you know now exactly what I mean, that there is a tumor which has a capsule. It is got follicles inside that tumor. Okay, there are no papillary areas in that at all. So the question of this being papillary does not arise. This is just a follicular patterned neoplasm. Throughout this encapsulated lesion, you have follicles, follicles, follicles. Now there are two situations in which you will come across. One of the situations is the normal, usual situation, which is look at the right side of this algorithm. You will see an encapsulated follicular pattern lesion which has no nuclear features of papillary carcinoma present. Okay, if there are no nuclear features of papillary carcinoma, that means there are no ground glass, there is nothing that would indicate that it was a papillary carcinoma, then it is either invasive or non-invasive. If it is non-invasive, we call it a follicular adenoma. If it is invasive, we call it a follicular carcinoma, whichever way you want to say encapsulated follicular carcinoma, meaning that it's invaded its capsule. But on the other hand, what if you had an encapsulated tumor which is entirely follicular, but it has the nuclear features of a papillary carcinoma in that neoplasm? What are you going to call it? Well, according to the definition, anything, whether it's encapsulated, whether it is entirely follicular, whether it has some papillae or not, if you have the nuclear features of papillary thyroid carcinoma present, you will have to call it, according to the definition, a papillary carcinoma. And then you add some qualification to that. What do you say? It's encapsulated follicular variant of papillary thyroid carcinoma. So it was an EFVPTC. So now it looks great, no? Look, it's also easy. If you have an encapsulated lesion, it is entirely follicular, it has no nuclear features of papillary thyroid carcinoma. All you have to find out is it invasive or it is not? You are absolutely then clear. You've got a follicular adenoma, which is benign, and you have a follicular carcinoma because this tumor has invaded its capsule or has shown angioinvasion. On the other hand, if these cells within that encapsulated lesion are all showing a follicular pattern, but their nuclear features are those of a papillary thyroid carcinoma, classical with all the, with orphanany, or it's got clearing, or it's, there are these holes within the nuclei, and there is grooving, and there is overlapping, and all of that, then according to the definition, you are forced to call it a papillary carcinoma. Okay? Because as we said before, there are no papillary adenomas, period. So there is no question of whether something is invasive or non-invasive. You have a completely encapsulated lesion. It's all follicular. It shows the nuclear features of papillary thyroid carcinoma. You have no choice. According to the definition, you have to call it an encapsulated follicular variant of papillary thyroid carcinoma. I hope that you understand this. I think those who have been doing thyroid pathology for some time are very well aware of this definition, and the younger people probably are beginning to understand that this is the way that we had to do things in the past. But as usual, things look very clear-cut and everything seems fine, but this is now, we don't live in the Garden of Eden. We don't live in paradise, right? So there are things that are always, always difficult. So what is this trouble? And the first thing is, what constitutes encapsulation? Okay. How do you distinguish a nodule? And when I say dysfunctional nodule, that is the term that I like to use and a lot of people like to use for those nodules that you see in a nodular goiter. Okay. So how do you distinguish a dysfunctional nodule from a follicular adenoma? In other words, how do you define encapsulation? The second problem that comes up with this whole issue of follicular pattern, encapsulated follicular pattern lesions is, what are the criteria for invasion in an encapsulated tumor? And that would make a difference between calling something a follicular adenoma versus a minimally invasive follicular carcinoma. Because as I told you, a carcinoma is by definition something that is invasive. So there is a capsule. Now, how much of the capsule should be invasion? What do you think constitutes the minimum definition for capsular invasion? And let me tell you, this is not as easy as it sounds. The second thing is, with respect to these PTC-like nuclei, that's papillary thyroid carcinoma nuclei, what if the whole thing doesn't show you these nuclei? What if they are just a few areas that show it? How much of it should show you this PTC-like nuclei, right? And what if the nuclei are not all exactly the same? Meaning, how much clearing do you require in each nucleus? Can you do it if you don't find, can you make this diagnosis if you don't find grooves? Can you make the diagnosis if there is no overlapping? Oh, the tumors, as I say, don't read the textbooks that we write. Okay, so the difference then would be making a diagnosis of a follicular adenoma or a follicular carcinoma, if there is some invasion over there, versus an encapsulated follicular variant of papillary thyroid carcinoma. So there are issues. Let's try and address them one by one. And these issues are really the cause of pathological thyrophobia, and a lot of second opinion work is generated by this "what if I get it wrong" syndrome, because people spend lots of hours. Technicians are asked to cut serial sections. People are running around trying to find out if there are endothelial there is a lining to some space into which this thyroid tumor seems to be invading, etc. And this "what if I get it wrong" syndrome comes from this controversies in the management of differentiated thyroid carcinoma. And what do I mean by that? Not just tumors that are encapsulated, but full-blown papillary carcinomas, follicular carcinomas that are differentiated. How should they be treated? Should one do a lobectomy, that is lobectomy, and they usually take out the isthmus, or should one do a total thyroidectomy? Of course, you might think, God, if this is a thyroid carcinoma, of course the whole organ should be removed. Why should we keep one part of the organ behind? We can discuss that at a later date. And that begs this question: should all carcinoma diagnoses warrant a total thyroidectomy? Then there are many surgeons who believe exactly this, that any carcinoma diagnosis means that he or she will recommend a total thyroidectomy to the patient. Okay, and then many of these kind of surgeons also don't follow what is called risk-adapted therapy. The criteria also for risk-adapted therapy, some people believe that they are too liberal, others believe that they are too stringent, etc. So they are not universally applied in practice. At the end of the talk, I will tell you what this risk-adapted therapy is and why it needs to be understood not just by treating physicians, but should be understood by us. Because if this is the case, then we will get out of this "what if I get it wrong" syndrome. Okay, so now let's just quickly do dysfunctional nodule versus follicular adenoma. Here is a thyroid, it's a section from a thyroid that was removed. And I think that most people would call something that is like the big encapsulated lesion in this section a follicular adenoma. I know I've put a query over there. I would have called it a follicular adenoma, but if you go through this, you see other nodules, okay? And there is no encapsulation for these nodules. Now, will somebody then ask me, and I'm sure it goes through many people's minds, maybe this is not a follicular adenoma, maybe it's a follicular carcinoma, and one of these small nodules, at least the one on the left, maybe it is, it's an extra capsular extension of this tumor. I don't think it is. We see so many of these in our practice. It's becoming rarer and rarer in the West, because in the West you don't see much of thyroid nodules. Why? Because their salt is iodized. They don't live in goitrous zones anymore. We are also seeing less and less of this now. And if we do see this disease of dysfunctional nodules, or what we call nodular goiter, it is in people who don't use iodized salt and perhaps live in in the sub-Himalayan areas and places like that, where iodine deficiency is still a problem. Not all over, because I think the Indian state has done very well with respect to promoting iodized salt. But there are older individuals, maybe my age or some a little younger, who have not had the benefit of this for much of their lives, perhaps still get nodular goiters, or have other reasons to get nodular goiters. So this, I think, we wouldn't be too bothered about. And so if you go to the WHO, or you go to any textbook, they will tell you that a follicular adenoma should be solitary, and I contest that. It must have a complete capsule, fair. There should be compressed thyroid tissue beyond the capsule, okay. By and large, there usually is. And the morphology within and without the nodule is different. These are definitions, okay. Sometimes you need to take all definitions with a pinch of salt, particularly when it doesn't make any difference at all, as it doesn't in these cases, because you just look at the questions and look at the answers, okay. The first question is: an encapsulated nodule in a multinodular goiter a follicular adenoma? And I showed you a case, and you might say, yeah, of course, because it fulfills all the definitions. But just think, okay, if people have done this work, 70% of dysfunctional nodules are clonal, and we normally take clonality. Whether we should or not is another question, and it is for another day altogether, when somebody is discussing neoplasia and whether clonality equals being neoplastic. But 70% of dysfunctional nodules are clonal. So suppose it doesn't have a capsule. Suppose, like I showed you in the previous case, all right, over here, there's no capsule. There's what is inside and outside and all that. Some of them look different from what's outside. Some of these nodules look the same as what's outside. What do you think? That we should call them all follicular adenomas, or call everything a dysfunctional nodule? Well, I don't think, as you see in the bottom line over there, it makes no difference in practice. Both are benign. Both don't require any other consideration from the point of view of treatment, okay? Moreover, you will see that some of these tumors, some of these nodules express the markers that are seen commonly in follicular adenomas and follicular carcinomas, and that is RAS mutations, okay? Or it's a very common thing. So I think that we shouldn't get into this exercise at all. Let's just keep it away, because, as I said, people are reluctant to call multiple dysfunctional nodules if they have capsules. Nobody, because it's supposed to be solitary, people don't want to call them multiple adenomas. I don't think it makes a difference, but I'll tell you how this has been addressed in the latest 2022. What's coming out? It's probably not out yet. WHO, because people understand, those who live in goitrous zones understand that this is not an uncommon phenomenon to have multiple encapsulated nodules. And so they have come up with, with a name, and that is thyroid follicular nodular disease, FND. Now, what were we saying? We were calling them nodular goiters, okay? But that was not good enough for the WHO, and they must have spent hours of, sort of arguing about what is the best consensus name for this thing, but you can call it thyroid follicular nodular disease. And they've called it an enigmatic entity. I don't know what is enigmatic about this entity. Enigma means it is a very strange, unexplainable condition. I don't think that this is enigmatic, but if anybody wants to use this new fashionable name, please go ahead and use it. Understand that it doesn't make any difference at all. And as I'll just put up a quote. I'll put up a quote from my mentor at the Royal Marsden Hospital, whom I think of very fondly because he had a, saying for so many things. And I quote them almost automatically because he used to use them so often. And you know what he used to say? When I went with something that I was not able to put a label to, he said, and if it was not worth the arguing about this label or that, he would say, call it anything you want, doctor, but don't call it a cancer. So that is the issue of the dysfunctional nodule versus a follicular adenoma. It makes no difference what you call it, so call it whatever you want. If there are many nodules, please call it by its new name, and that is follicular nodular disease. Okay, but here is something a little bit more important, and that is, how do you tell a follicular adenoma versus a minimally invasive follicular carcinoma, where the capsule is very obviously there, but the capsule is irregular, and the capsule appears like it might be penetrated. Okay, then it's not a question of just a dysfunctional nodule versus a follicular adenoma. It's more serious than that. Okay. So there were definitions, and this minimally invasive follicular carcinoma, particularly in both, I would say the 2004 definition and a definition that came out with the AFIP, because the Armed Forces Institute of Pathology also you would bring out its own classification of tumors. Well, this was what it was. A minimally invasive follicular carcinoma is an encapsulated follicular neoplasm. And when we use the word encapsulated, we mean that it has a capsule. Okay, so it's not just circumscribed. It has a capsule, which demonstrate invasive characteristics. And when I am using this term follicular neoplasm, I am once again saying it means that the entire lesion shows follicles. Okay, it is the definition of what is a follicular neoplasm. So it demonstrates invasive characteristics. Capsular invasion, what was said, it had to be full thickness invasion of the capsule. And in most cases, the capsule was thick, multiple layers of collagen. Vascular invasion, now this is one of these definitions, which are not easy to apply. Okay, it's tumor emboli. Everybody knows what is a tumor embolus. This must be seen within or outside the fibrous capsule. So nobody looks for vascular invasion within the tumor itself. And by and large, this is true of all other tumors. Whether you take breast, I don't think that we look for lymphovascular invasion within the main breast tumor. We always look for it somewhere at the periphery, because this tells you that it's not easy to look for vessels within the tube. Okay, now that is all right. You must look for tumor emboli within vessels within or outside the fibrous capsule, and the tumor embolus must be covered by endothelium. This is one of the most, I would say, difficult things to sort out. If whether or not you can do endothelial immunohistochemical markers for endothelium. And frankly, I just say it's like a definition of pornography, right? you know pornography when you see it. So you don't need, a great debate over whether something is or is not. So this is that sort of definition, but I take it that there may be instances where you do not know whether it is or not, and I would, if I am not sure that something is a vascular embolus, please don't call it a vascular embolus, is the way that I take it. It has to be 100% absolutely sure. You show it to your neighbor, that means your colleague, or you show it to somebody else. And if you have no dissension about this being vascular invasion, then it is vascular invasion. It just must look like vascular invasion, but please use this definition if you feel that it is so. Now, here is what I would show as on the left-hand side, and somebody would say, hey, it doesn't look really full thickness. Well, it really doesn't look full thickness. You will notice that this is what is outside this capsule. It's not thyroid tissue. This thing is sitting next to the thyroid capsule, in fact. Okay, so there is nothing further beyond which it can actually go. It's a nice mushroom-shaped, sort of invasion. And you notice that there is a cinch. You know what is a cinch? C-I-N-C-H. It's a waistband. So something that is constricting something. So if you see that there is a capsule on one side, there is a capsule on the other, and you have this mushroom that has gone out. Also notice that this is not at the site of an FNAC, because if you have had an FNAC, you will see the needle tract, you will see some hemosidrin, you will probably see a small hemorrhage in that area, however small it is, because the needle is fine. And sometimes that needle tract splits the capsule, and because you're aspirating, the thyroid tumor, which is relatively vascular and soft, it doesn't have much stroma, will sort of pout through that particular needle tract, and there is none over here. So these are the few things that you have to be careful about before you say this. Now here, I would call this angioinvasion without a doubt. Some people might say, oh, where do you find the endothelium or whatever? But as I told you, if you think that it's angioinvasion and you show it to your colleagues and they all agree, if somebody has some reservations, then take the consensus diagnosis on that. But this is angioinvasion as far as I'm concerned. Now, somebody tried to put this together, not somebody, this Dr. Ronald Gossain, who's at a memorial, made this very nice figure. Look at the figure. Okay, the green thing is the capsule. All right, and this green thing has got, he's shown you all the different possibilities that you might have. Now, if you take C is an open and shut case. Okay, the open and shut case means what? That there is a tumor and it has gone out through this green capsule. So I don't think there is anybody who would question this capsule. Yes, you see this here, E. Yeah, it's outside the capsule and it looks exactly the same color and morphology, etc. So it is there. H, yes, without a doubt. Okay, but you see, I put 3 arrows here. You know, these checkered arrows. Well, you look at this. You see this green thing that he has shown? There is a capsule beyond it. And Dr. Gossain has still said that it is yes. Now, you might say the definition says that there should be no capsule. It should be full thickness beyond this tumor. So why? Why is this why has he said yes? Because you can have, in a slow-growing tumor, penetration beyond the capsule and the formation of a new capsule, okay? So this is a newly formed capsule, and he has shown this by some little hatches over there, which says that the capsule was once there. Now, this is very, very difficult to, sort of establish or even to evaluate in tumors. But I think if you've got a thick capsule and you see that that capsule is split, whether or not there is some thing that looks like a capsule beyond it, you can be sure that this tumor is invasive. Okay. Now here is a controversial thing. There is a little hillock that is going in this thing that is B. Okay. And he says, not yet. All right, what do you mean by not yet? So will it actually get in through? Yeah, it probably does. And it is telling you something. If that capsule is thick and there is something going through, okay, according to the definition, it is not yet gone through, but I think it will any minute. And so also will this one, which is like a mushroom, but there is a capsule beyond it. And it may be something similar to what I showed you. I feel that these are really very, very minor kinds of problems. And we will see what they actually mean. Are we just splitting hair? Okay, we'll talk about that. Then similarly here, this is for vascular invasion. He says, yes, if you have something that is lined by endothelium. And he says, yes, in the capsule, if you have something. So there are lots of yeses. And he says that, just something being pushed in by cutting artifact is not, it should not be considered vascular invasion. Okay. Now, I showed you this one. It's not the same one that I showed you before. Would you say yes or no? I would say yes. I don't know what other people would say. I think that this is, again, an example of this thing going through the epithelium. And, another capsule has formed, and beyond that, you have the thyroid capsule. On the right-hand side, this is a very high-grade tumor, but I'm only showing you that you see a kind of almost like what we would call a septum going in from the capsule into that. Now, that's not a septum going from the capsule into that. That is, the tumor has kind of gone through into the capsule and has disrupted the capsule, so it looks as if there is a septum that has gone down into the capsule. I'm just showing you this is a high-grade tumor, and yet it is encapsulated. Okay, now here is this famous hook. Okay, there is a hook-like extension of the tumor into a thickish capsule. Now, if you read about this, there are many people who are considered experts. They see a lot of thyroid work and are the ones who actually make these definitions. And you see here, there is partial but incomplete penetration of the capsule by the tumor has been widely regarded by some as being sufficient to qualify for invasion. And I think amongst the some, maybe I am included in that. And therefore, for a diagnosis of carcinoma. However, as you have seen, a consensus regarding the significance. Now that is important, okay? It is the significance of such a finding is not yet available. Somebody is confessing that this is a problem. And what do we mean by significance? It means how is this lesion likely to behave and what should we do about it in the short term? Okay, and this is not so long ago. This is 2019, just before the COVID came in and struck us. So it is about 2.5 years ago, and they have addressed this to a certain extent in 2022, and everybody will be wiser thereafter. Now here is another thing, and I feel that this is not only invading the capsule, it's also invading an intracapsular vessel. And how do I know that? Because there is a fibrin thrombus. Okay, so when you see a fibrin thrombus associated with a vessel in which there is tumor, just don't bother to go look for, is there endothelium, is there no endothelium? There cannot be, a thrombus. unless the endothelium has been damaged, which happens when the tumor, which could happen when the tumor penetrates the vessel wall. Okay, right. Now I'm just showing you this because you have Suster, who I just quoted, on the one hand, and he published this paper in Lab Medicine in 2006. And on the right-hand side, there is Baloch, who is a very closely associated with Virginia Livolsi, who wrote this almost contemporaneous, papers. Now, what does Suster say? Suster says he's showing you minimal irregularities of the capsule should not be considered as evidence because that is in keeping with whatever he has been saying. That's what he said in his 2019 article, that people might want to call this carcinoma, but the significance of it has not been elucidated. So he shows here in the top right-hand corner something that I would, of course, I would take sections and other such things, but I would be inclined to call an invasion of the capsule. Okay, the bottom one I most certainly would not have called an invasion of the capsule, but he says that even the top one should not be called evidence of capsular invasion. Okay, in a follicular patterned neoplasm. But look at Virginia Livolsi and Baloch. Yeah, his name is Zubair Baloch. Look what they say, that capsular, they're showing it as an example of capsular invasion in follicular carcinoma, showing tumor cells invading into but not through the tumor capsule, and they're calling this a hook. All right, it is less of a hook than the hook that I showed you in the last case, which Suster would not have called an invasion. Okay, a hook-like fashion. Some pathologists consider this an atypical adenoma. That means she would have considered it. Virginia is a lady, would have considered this evidence of capsular invasion, would have reported it as such, but she believes that some other people, and perhaps she means somebody like Dr. Suster, would call it a tumor of uncertain malignant potential because they would not think that this was sufficient evidence of invasion of the capsule. Okay, so I've shown you all the different opinions as to why there is so much anxiety amongst people who are reporting on thyroid tumors. Yes, and the real issue is the significance. How do these lesions behave and how should we deal with them? Okay, good. Now here is a case, and I really commend the authors for publishing this case, and you can go and look at it. It's in a relatively obscure journal. It's called the Journal of Basic and Clinical Medicine. Okay, now just read this. This was a consultation case which was sent to these authors. Yeah, it was a 61-year-old female who developed metastases. It was metastatic thyroid carcinoma in the sacral vertebra. Okay, and the review of the histological slides of the primary thyroid nodule treated at a local hospital 14 years ago. All right, so that person, this lady, 61-year-old female, had, and remember now, just note that she's 61 years old. If you minus 14 years from her age, she would be somewhere around 45 or thereabouts. Okay. Now, at that time, she had this thyroid nodule and they showed the pictures. Okay. And the question was, in A, would you call this, questionable capsular invasion? You see the capsule, you see something sitting outside the capsule. Yeah, there is a little bit of what somebody might consider a capsule at still present at that end, and then you have normal thyroid tissue. Okay, and here I think I would not have called that angioinvasion. Yeah, although you can see that there is some endothelium lining, something that is pushing its way into a vessel. There certainly is no fibrin thrombus. Now, are you going to fault this individual for calling this thing whatever they had called it at that time. They didn't say what it was called, but it was obviously not called a carcinoma, and therefore less than a total thyroidectomy was done in this particular case. And please, I'm wanting you to remember something that I'm going to say now, and just mark my words, okay? Less than a total thyroidectomy was done. I'm asking the question, if a total thyroidectomy had been done in this case, would this patient not have had a metastasis? Okay, just remember this question when we sort of try to explain or understand what is the significance of capsular invasion. Okay, and I just put up this Ronald Gossain's article, this diagram over there, because if you take this as capsular, not yet capsular invasion, then it is exactly this, in this diagram, I represents that, not yet. So Ronald Gossain would not have called this a capsular invasion. And nonetheless, this tumor has behaved like a follicular, minimally invasive follicular carcinoma, which has shown its metastatic potential by actually having metastasized 14 years later. Okay, this is the story of this. So if you were Suster or one of these people who don't want to come back on one, come down on one side or the other of the fence, then you would call this a follicular tumor of uncertain malignant potential. Makes it very difficult. Things like FATUMP or whatever you wanted to call it. Now let us also look at something molecular. Okay, molecular markers are shared between follicular adenoma and follicular carcinoma of any kind, even minimally invasive follicular carcinoma. Okay, these are the markers that are associated with follicular adenomas and carcinomas. There is this RAS gene mutations, there is the PAX8, PPAR gamma rearrangement. And when you do a full gene expression profiling, that is very interesting. It shows similarities between a follicular adenoma and a minimally invasive, capsulo-invasive, encapsulated follicular carcinoma. Okay, but when you're talking about angio-invasive encapsulated follicular carcinoma, the gene expression profile, you do a number of genes and to see what the similarities are is somewhat different. So it may mean that if a tumor is angio-invasive, its metastatic potential, or it may be a different animal altogether. And it maybe should not be lumped with a follicular adenoma and just a capsular invasive follicular carcinoma, which we call a minimally invasive follicular carcinoma. What I'm saying is, and what most people now believe, that an angio-invasive follicular carcinoma should not be lumped in this group of minimally invasive follicular carcinomas. It should be kept separately. Okay, so this is just, I don't want to, this is exactly what the WHO said, and we have discussed all this. This was what their definition was. Gossain tried to show that if you had less than 4 foci of angio-invasion in any tumor, it did better than, than something that was not. But I don't think that people really worry too much about this sort of thing. There are better predictors of behavior. Angio-invasion by itself is bad. And I don't think we should quibble about whether there are 4 foci or less than 4 foci. Or more, sorry, more than 4 foci. So just to, sort of summarize what I have said so far, that if you took metastatic behavior of encapsulated follicular patterned tumors, okay, these follicular tumors with extensive transcapsular invasion or unquestionable vascular invasion, and I don't think that the four foci and less than 4 foci makes any difference. show a definite risk for metastasis. And extensive means, I mean, if you don't have to look, you just take sections and you'll find that there are numerous, for all practical purposes, that capsule has been transgressed extensively. And what's important here is that any other encapsulated follicular tumor, now just look at that, is unlikely to metastasize and probably does not merit aggressive therapy, that is total thyroidectomy and radioiodine ablation. And then you will come back to me and say, but what about that case that was published? Yes, so remember that case that was published and we will talk what about it. Okay, so as I said, this was going on in WHO 2004. We have minimally invasive and we have widely invasive. And in the minimally invasive, there was both angio invasion as well as capsular invasion. Somewhere between 2004 and 2017, which is a long number of years, 13 years before they updated the classification. In 2015, the AFIP came up with this classification, and they also used minimally invasive and widely invasive. And in the minimally invasive, they said that you should grade them into capsular invasion, alone, limited vascular invasion, extensive vascular invasion. Okay, so that was the AFIP version. But what did the WHO 2017, which is still in force until the 2022 comes out, they said you had to, there were three different, and you can see by the shading of the, the shading that has been used, there is minimally invasive, there is encapsulated angio-invasive. So they have now separated the encapsulated angio-invasive tumors as a separate, more aggressive group, because this is about aggression, okay? So minimally invasive, encapsulated angio-invasive, and then widely invasive. So this was how it was in 2017. Very good. So let's now park that whole story of the follicular adenoma, follicular carcinoma, minimally invasive, angio-invasive, and let's go on to the next issue, and that was the problem of the encapsulated follicular variant of papillary thyroid carcinoma, which was being referred to even as far as the classification just before 2017 as the encapsulated follicular variant of papillary thyroid carcinoma. Okay, and this has been the cause of much thyrophobia. And anybody who has practiced thyroid carcinoma, and there may be also students who are who listen to lectures and have lots of thoughts going through their minds. This on your right-hand side is a classical papillary thyroid carcinoma nucleus. I don't think anybody would have any problems with that. And also you can see that there is the thick chewing gum, as they call it, colloid, that is present within these follicles. There is no papillation here at all. It is entirely follicular, and it is entirely showing you the follicular, the papillary thyroid nuclei. Okay, so I don't think anybody has this a problem about this at all. But why then do we have this this anxiety? Why? Because there are sometimes equivocal nuclear features of papillary thyroid carcinoma. Just like that angio invasion, the capsular invasion thing, I show it to half a dozen people. Some say, no, there's not enough. I can't see this or I can't see that. Others will say, no, I will accept this as papillary thyroid. So there is, you can't get people to agree that there is, these are nuclear features of papillary thyroid carcinomas. And then maybe there is a focus that is absolutely like a papillary thyroid carcinoma. Nuclear features and are very prominent. But then how much is enough? Is that one focus enough? Should it be 50% or more? Now, like most things, they'll say 50% or more. All right. But what does the rest of that 50% actually stand for? Okay, fine. So this is the real issue. And then the question, as I've just said, that this was very easy to diagnose when there was nothing it was very difficult. But the real question was, and I realized this a long time ago, that the majority of these cases never did anything. Okay, they had an excellent prognosis. They did not metastasize. They didn't go to the lymph nodes. They did not behave like papillary thyroid carcinomas, yet we were calling them papillary thyroid carcinomas, okay? And then people would come out, oh, but there was these multifocal nuclear features in a tumor, and these patients had late systemic metastasis. When you went through those reports, you discovered that those cases had angioinvasion. So we were not just talking about any old encapsulated follicular variant. If you had angioinvasion through the capsule, that was bad disease, just like it was with follicular, encapsulated follicular carcinomas. So if there was no angioinvasion and you had a completely follicular patterned lesion and it was showing the papillary thyroid carcinoma nuclei, they never did anything to the patients. Yet somebody stamped this, and I did it as well. Okay, in fact, the case that I showed you before, I called it an EFVPTC. Okay, but that was as far as I was willing to go. Anything that was less did not show complete a complete nuclear, that the whole tumor was not showing you these features, or the majority of the tumor was not showing these features, and there was a little bit here and a little bit there, I would just ignore those and call that a follicular adenoma, because I knew what my report was going to mean for the patient. And what was that going to mean? That the patient would receive a total thyroidectomy. In a large number of surgeons would do that. Okay, so I wanted complete, the entire, when I say majority, may have been 90% of the tumor showed you the papillary thyroid nuclei. Okay. And this was the story. Many surgeons would perform a total thyroidectomy just because of the word carcinoma. And if you sent it to an expert, the opinion was often at variance. And I always say that if you want an expert opinion, then send it to an expert who will agree with you. That's the best way to get an opinion in your favor. But this was true. There were experts who did not agree when you sent it for a second opinion. And as a result of this, you have no idea how the numbers of papillary thyroid carcinomas just jumped in this world. Why? Because all these encapsulated lesions that were showing papillary thyroid nuclei were suddenly all being called papillary thyroid carcinomas, and there were lots and lots of people who had very low thresholds for calling these things papillary thyroid carcinoma. Okay, now here is a case. I'm showing you at high power what these nuclei look. This tumor otherwise looks like a follicular adenoma. There's no chewing gum colloid. There is nothing. There are just these nice vacant looking nuclei. There are no grooves. There is no nuclear overlapping. But what are you going to call this? Okay. In my opinion, this is not a papillary thyroid carcinoma, encapsulated variant of follicular variant of papillary thyroid carcinoma, and I wouldn't have called it so. But yes, there are many people who would call it so. So what to call it? I certainly wouldn't call it that. Should you call it a follicular adenoma with some nuclear features of papillary thyroid carcinoma? Yeah, if you want to. What is the surgeon supposed to do with that report? And then you confess and say, I don't know whether this is a follicular adenoma because there is no invasion, okay, or a follicular variant of papillary thyroid carcinoma, which is encapsulated. Or you invent a name, and some people did invent a name, okay? And this name was invented because these people saw many of these lesions after the Chernobyl explosion, the nuclear explosion in Belarus, you'll notice some people here. People will notice there was a group that was asked to study all the thyroid tumors that there was a number of new cases of thyroid tumor in those that were exposed to the radiation. And here you know that here is one Rosai, that is John Casey Chan. This is E.D. Williams. E.D. Williams was the leader of that group. When you see Virginia Livolsi, I think this is a younger looking Sylvia Asa. I'm not sure who the rest of these people are, but they have the same problem that you and I have. Okay, you had nuclear features of papillary thyroid carcinoma and in these encapsulated lesions. And they said, if it was with or without capsular invasion, you call that a papillary thyroid carcinoma. That is EFVPTC. That was the view at that time, and that's what they called it. However, if all these nuclear features were equivocal, okay, and on top of that, there was definite capsular or vascular invasion, then they call this tumor a well-differentiated carcinoma. They didn't know whether it should be put in the follicular group or the papillary group because the nuclear features were like what I showed you now, equivocal. And they said it was a well-differentiated carcinoma, not otherwise specified, okay? On the other hand, you didn't have definite capsular or vascular invasion, okay? It was questionable, so they called it well-differentiated tumor of uncertain malignant potential. The same way as you had the follicular tumor of uncertain malignant potential, then here is this tumor of uncertain malignant potential, except you won't call it follicular because you don't know that nuclear features are equivocal. So you called it a well-differentiated thyroid tumor. It was obviously encapsulated of uncertain malignant potential. So that was the name that was devised. Now, fine, we have all the names, we have everything. Can we apply them, and how do experts apply them? Okay, now here was a paper that was published in 2004. There were 87 tumors that were given to 10 experts. There was nobody who was not an expert, okay? And these experts classified these tumors into follicular variant papillary carcinoma, follicular adenoma, follicular carcinoma, follicular adenoma carcinomas, and others. Now I've just made a box, okay? And there are two boxes. And you see that there are at least 5 people, okay? Now, expert 1, 5, 6, 7, 8, who will call almost anything follicular variant of papillary thyroid carcinoma. Almost anything. And there are 2 experts who called everything, 100%. Papillary thyroid carcinoma. On the other hand, there are others who will call things follicular adenoma, and I suppose I might have been in that, although I was not asked to be on this expert panel. I might have been part of this, 2, 3, 4, 9, and 10, where some things I would call follicular variant of papillary thyroid carcinoma, and the others I would probably call a follicular adenoma, okay? Because I wouldn't, if there was no invasion at all, I wouldn't see the need where you had equivocal features to put this into the follicular variant of papillary thyroid carcinoma group. So experts do not agree, okay? So what is the solution to this inter-observer variation in the diagnosis? So, there was, that John Casey Chan was there, right? And Chan had published his criteria in 2002. If you use strict criteria, you will not have this problem, okay? But these strict criteria, I suppose, were used in that last, paper, and still you had this problem, and worse still, in as late as 2008, much after John Casey Chan's criteria, much after that other paper that was published. Look at this. Okay, again, you have another paper that is telling you the same thing. Here you had 6 experts, and you had 15 cases. Okay, and I'm just asking you to look at expert number 5, expert number 6, and expert number 3. All right. Expert number 3 and 5 called almost everything follicular variant of papillary thyroid carcinoma. At least expert number 3 had one follicular adenoma or two follicular adenomas. Okay. Just look at expert number 5, except one thing that case number 2, which everybody called benign, expert number 5 called everything follicular variant of papillary thyroid carcinoma. And expert number 6 found everything benign except for 2 cases of follicular variant of papillary thyroid carcinoma. I know that this is very, very disappointing to everybody, but it is the truth. Okay, this is how it goes in thyroid pathology. And once again, I bring you back to what Suster said. All right, you may call anything, but what is the significance of what it is that you are calling? Yeah, and also the case that I showed you, which was very honestly reported that somebody had called this thing benign and this tumor actually metastasized. And what was the lesson that we could learn from that? Funnily enough, when they showed the same cases after mixing it up to the same experts, there was only one expert who was 100% no intra-observer variation, because that person called everything follicular variant of papillary thyroid carcinoma, and that was number 5. But look at the others. Is there any intra-observer variation? Of course there is intra-observer variation, because the same expert called something when he saw it the first time, or she saw it the first time, something. When it was shown again, the the diagnosis changed. So it depended on which side of the bed that expert got out of, except for expert number 5. Okay. So now, did it matter? And I'm telling you here, somebody really went to find out, did it actually matter? And you see that they changed the diagnosis, okay, from 30, for all these follicular neoplasms, from 36% benign to 48%. No, it went from 36% malignant to 48% malignant. But see what was important here. There are no clinical ramifications. There were none, because this was a retrospective study. In the patients with the changed diagnosis, they were all well. They had no problems about these in these cases. So what was the implication or the significance of changing that diagnosis from 36, making 36% malignancy into 48% malignancy? Have you done those patients a favor by now telling them that they are malignant? And I think that long ago, there was a very nice paper, which I don't think has been quoted by any of the later authors who tried to make some sense out of this. And again, it came from Memorial, where Ronald Gossain is. And what did this paper say? The paper said that when you are dealing with the follicular variant of papillary thyroid carcinoma, you have 2 histological scenarios, and these 2 scenarios have got their own clinical implications. If you have an infiltrative follicular variant of papillary thyroid carcinoma, which is non-encapsulated, that means it's a diffuse tumor in the thyroid, and we do see these cases. They are not very common. They are entirely follicular, but they are diffuse. There is no question of a capsule or anything over there. This one resembles the classic papillary carcinoma in its metastatic lymph node pattern and invasive growth. On the other hand, you have what we have now been talking about for the last maybe 10-15 minutes, and that is the encapsulated form, okay, which behaves, as they said, more like a follicular adenoma or a follicular carcinoma. That's depending on minimally invasive follicular cancer. They do not develop lymph node metastases or recurrences, and see that they could be treated by lobectomy alone. And if they say the current findings are confirmed, then strong consideration should be given to reclassifying encapsulated FVPTC, which is what we have been talking about, as an entity that is closer to a follicular adenoma or a follicular, minimally invasive follicular carcinoma. Somewhere this was lost in, I'm sure that those who did a lot of thyroid work knew about it, but it was a very important paper. So then now we have to ask this question, is or was what we were calling an encapsulated follicular variant of papillary thyroid carcinoma really a papillary carcinoma? Okay, because it is, behavior is not like that of a papillary carcinoma. Its behavior is very like a follicular patterned tumor, the usual follicular tumors, whether adenoma or minimally invasive follicular cancer. So, well, we've just found out that it does not behave like a PTC. Look at its molecular profile. It does not have the RET mutations. It does not have the BRAF mutations that are commonly found in papillary thyroid carcinomas. It has RAS mutations similar to those seen in FAFC. They do not, this PPAR8, PPAR gamma, which is also seen in FAFC, have been found in a few cases, but mostly they show you RAS mutations. So, and you don't see RAS mutations in the classic papillary thyroid carcinoma. So, is it really a papillary thyroid carcinoma? And the answer is obviously not. And there is a morphological overlap, okay, between this papillary thyroid carcinoma and the classical papillary thyroid carcinoma because of the nuclear features. But when it is encapsulated, this thing has a relationship, molecular and behavior, in terms of its molecular patterns and its behavior, like an follicular type of tumor. So that is a follicular and minimally adenoma or minimally invasive follicular tumor. So again, this is what Rosai was hinting at. Just because it has nuclear features of papillary carcinoma and it is entirely follicular and it is encapsulated, should we believe that its behavior is going to be like that of a papillary thyroid carcinoma? And the answer has become abundantly clear, it is not. Okay, now I had questions about this. Okay, I've had questions about it a very long time, and I made, I asked these continuously to myself and to people whenever I used to be at conferences and I could talk to the experts. And I asked this question, which I think is the most fundamental question. If we believe that this, because there are papillary thyroid carcinoma nuclei, it is a papillary thyroid carcinoma, and if we have found out that this is more closely related to a follicular adenoma or a minimally invasive follicular carcinoma, then should you not use the same criteria that you use for follicular adenoma and follicular carcinoma for defining benign versus malignant than those that we are using just because there are nuclear features? So should you not call these things benign adenoma? Minimally invasive without angioinvasion and minimally invasive with angioinvasion. Why are we calling them all carcinomas? Papillary thyroid carcinoma. And then came the main question, should the definition of a follicular neoplasm, that means one which has got a follicular pattern, always remain one by exclusion, meaning just because, I told you, by exclusion means that if it doesn't have papillary thyroid nuclei, then you call it a follicular neoplasm. Otherwise, you call it a papillary thyroid neoplasm. And I was very, very wary of this. And then comes the next question, should the diagnosis of encapsulated follicular pattern lesions incorporate molecular profiling? Okay, and the answer is, well, it might make more sense, but really ultimately is the question, does it matter? And if so, when does it matter? and I put this up because I think this is one of the most, I think, thoughtful things that somebody has said about cancer. Okay, and this is the great Julian Huxley. Everybody of you have heard of Aldous Huxley, who wrote this famous novel 1984 about a dystopian society. Well, Julian Huxley was his brother, and he was a biologist, and he was asked to give a lecture at MSKCC, and he asked this, he made the statement. He said, cancer, that is malignancy, must be defined in terms of what the tumor cells do, not what they look like. Otherwise, this term ceases to have biological meaning. And I think this is so true of this papillary thyroid nuclei. If you've got papillary thyroid nuclei, does it mean that it is a papillary thyroid carcinoma when we know that nothing happens to the encapsulated variant of papillary thyroid, of this follicular variant of papillary thyroid carcinoma? We're just calling it a carcinoma because it has these papillary thyroid nuclei. Okay, so I had in my mind a schema. Okay, and I made the schema and I gave this lecture to, to a thyroid society in Kerala. And what I said was that you have three possible scenarios when you have an encapsulated follicular patterned neoplasm. Now, remember, this is in 2015. Okay, I never realized what a fantastic bombshell was going to come in April 2016, right? So at that time, we were just looking at encapsulation and nuclear features of papillary thyroid carcinoma. So now nuclear features of papillary thyroid carcinoma, if you're convinced that they're there and they're all over there, and you have no problems with that, chewing gum, colloid, everything, I said, okay, call it the encapsulated follicular variant of papillary thyroid carcinoma. If the nuclear features of papillary thyroid carcinoma are absent, and it is a follicular pattern lesion, if it is non-invasive, of course, it's a follicular adenoma. If it is invasive, and you have seen angioinvasion, please just call it a follicular carcinoma, you unqualified, because angioinvasion is bad news for the patient. Okay? If it is invasive, but it does not have angioinvasive, it is just capsular invasion, call it minimally invasive follicular carcinoma. Right. But what happens if the nuclear features of papillary carcinoma are uncertain or focal? Okay, we've just gone through this. Uncertain or focal, what will you do? Well, use one of these terms if you like them. That is the well-differentiated thyroid tumor of uncertain malignant potential. Okay, that was my flow chart, my recommendation, and I did something further. I said that if you look at what is now encompassed in this blue background, I said that all of these lesions, okay, are encapsulated follicular patterned lesions of low clinical risk. And if you have something of low clinical risk, it falls into what we call the low risk adapted therapy. Okay, so risk adapted therapy is for low risk lesions and intermediate risk lesions and high risk lesions. And these tumors, from their histological point of view, would be of low clinical risk. The whole of this risk adapted therapy is not just about histology. It's about age. It is about metastasis. It is about, invasion of the thyroid capsule. But if you had this encapsulated follicular patterned neoplasm and it fell into one of these 4 groups that I have put into this blue box, then I was quite certain that these had low clinical risk. Okay, I have included in that what I was being asked to call, and which I guess I was forced to call, the encapsulated follicular variant of papillary thyroid carcinoma with very definite nuclear features of papillary thyroid carcinoma. Now, what is this bombshell? Here it is, published in JAMA on April 14, 2016. Okay, I had given this talk in sometime in September 2015, and here it came. And here is where we now have more sense in what is going on. The same thing that we were calling encapsulated follicular variant of papillary thyroid carcinoma. See that right there in the head, in the title. The nomenclature revision, which means the name has been changed for encapsulated follicular variant of papillary thyroid carcinoma. And now everybody knows what this is. We are calling it the NIFTP, non-invasive follicular thyroid neoplasm with papillary-like nuclear features, okay? And the reason that they did this, because these patients, see, all of the 109 patients with non-invasive EFVPTC treated with lobectomy alone, because there were some people who, like I told you, at Memorial, etc., refused to treat these with a total thyroidectomy. None receiving radioiodine ablation were alive with no evidence of disease at a median of 13 years. So if the median is 13, there are equal number of people above 13 years and below 13 years of follow-up, okay? Including 5 patients who developed distant metastasis and 2 of whom, an adverse event was seen in 12 of 101 cases, including 5 patients, but they were cases of invasive EFVPTC. Okay, so if you had no invasion, it was behaving like an adenoma. Okay, and they had the definition, and you can read the definition. I think it's important that we don't sort of overcall these lesions. So it had to have a follicular growth pattern, and they said with less than 1% of papillae, no Samoma bodies, because then you were probably dealing with a true papillary thyroid carcinoma, and no more than 30% solid trabecular insular growth. The nuclear features had to be, showing some nuclear features of papillary thyroid carcinoma, either full, that's 3, some 2, but things that didn't show anything, of course, was not considered. No vascular or capsular invasion, because they're talking about non-invasive, no tumor necrosis, and no high mitotic activity. Okay. A little later, the same people said that there have to be complete absence of papillae. So even 1% was not enough. But let me tell you that in 2002, the WHO is going to say less than 1% of papillae again. So anyway, these are the experts, and let them make up their minds. But whatever it is not invasive, and it is not being called a papillary thyroid carcinoma. Now, it is a follicular tumor with papillary thyroid nuclei. But this throws up some very interesting questions again. So, can the distinction of NIFTP from FVPTC be made on cytology? No, everybody is now busy, solitary nodules are being poked, and we are doing Bethesda classification, etc. And the answer is no. How can you know whether those follicular, you've got a follicular patterned lesion and there is papillary thyroid nuclei? Do you know whether that is invasive, non-invasive? Do you know whether this is actually a diffuse variant of papillary carcinoma of the thyroid with or not? I don't think you know that. So this is a problem. The next question. If absence of invasion is a criterion for the diagnosis of NIFTP, then why don't you call it a follicular adenoma with PTC-like nuclei? To me, that makes the most sense. But no, it was called follicular tumor, okay? Not a follicular adenoma. I might think that it is a follicular adenoma with PTC-like nuclei. Okay, have they defined how extensive should the foci with nuclear features be for the diagnosis of NIFTP? And not really. It is not defined. But I think that if an NIFTP is a RAS mutated, you can forget the PAX8 PPAR gamma. In other words, if it is a has a mutation that is normally seen in a follicular adenoma or a follicular carcinoma, then it is actually a follicular lesion with PTC-like nuclei. And why would then it matter at all? How extensive these nuclear features are? Because these are in any case follicular lesions. They belong in the FA/FC category. Okay. Now again, there is this important thing. What term should apply to a follicular patterned lesion with papillary thyroid nuclei with capsular or angioinvasion? Well, as far as I'm concerned, it makes sense to call it a minimally invasive or an angioinvasive encapsulated follicular carcinoma with PTC-like nuclei. But that's not what they are calling it. What are they calling it? Look what they're calling it. They're calling it invasive EFVPTC. Now, where did that come from? You just told me that the non-invasive, in fact, that whole article was dedicated to calling these lesions non-invasive follicular tumors with papillary thyroid nuclei, and they changed the name from encapsulated follicular variant of papillary thyroid carcinoma. But the moment it goes through, the same non-invasive thing goes through its capsule, or it invades the veins, the vessels, although it is RAS mutated, and you can see that it is RAS mutated, you want to call it encapsulated follicular variant of papillary thyroid carcinoma. I think that sometimes as pathologists, we are absolutely schizophrenic. Okay. So I don't agree with this at all. But I think that there is a reason why all this is happening, because of the possibility of, too much of a shock to the system, to get clinicians also on board with this kind of diagnosis. And that's the reason that this has been, we are still doing crazy things. Now, here is a case in point. Is this minimally invasive follicular tumor with papillary thyroid nuclei, or is this a true EFVPTC? This has got a lot of, if it has a lot of papillae, well, I would probably call it a papillary thyroid carcinoma if there are a lot of papillae. But if there are no papillae, then, and if it is a RAS mutated lesion, I think it's wrong to call this lesion if it didn't have papillae and encapsulated follicular variant of papillary thyroid carcinoma. This is again showing you the same thing, that these NIFTP is a RAS mutated lesion, which can then become a poorly differentiated thyroid carcinoma or even an anaplastic carcinoma if you get a P53 mutation or a TERT mutation or a PI3K or whatever P10 mutation in the lesion. Now, if you want to look at what the WHO classification of thyroid neoplasms is, I'm only showing you what is part of the encapsulated things in the blue box. Yeah, there are some interesting new things. There is a follicular adenoma with papillary architecture, and I'll show you a case, okay, which has got nothing to do with papillary thyroid carcinoma. I don't know why we get into all these semantic difficulties, okay. Now, Hürthle cells are not called Hürthle cells, they're called oncocytic adenomas of the thyroid. But I am so triumphant. Why? Because have you seen, there are benign tumors, there are low-risk neoplasms, and there are malignant neoplasms. And I want to pat myself on the back, because anybody with a little grain of common sense, I know I'm being immodest over here, but I feel that I felt that this should have been on the cards for a long time, okay? Low-risk neoplasms. And what are they? Non-invasive follicular thyroid neoplasm with papillary-like nuclei, that's NIFTP. Then these thyroid tumors of uncertain malignant potential, WTMT, or WTU-UMP, or FT-UMP, whatever you want to call them. And they've added hyalinizing trabecular neoplasm. And then you have the malignant neoplasms. And what are these malignant neoplasms? Follicular thyroid carcinoma, agreed. okay? And they have put invasive encapsulated follicular variant papillary carcinoma. And to me, that truly belongs in the low risk neoplasms, okay? Because if you have its non-invasive NIFTP there, this should also be there, the encapsulated follicular neoplasm. That's what I have. This is my one sort of critique, if you might say, or a difference between what has been published now and what what I think should have been done before. Okay, so you want to see what is a follicular adenoma with papillary architecture? I've taken it from Dr. Baloch's article. This is it. It's what we used to call Sanderson's, Polsters, and God knows whatever. It looks hyperplastic, but it is encapsulated, and you can see the capsule over there that they have shown. And we used to spend lots of sleepless nights looking at this and saying, is it really papillary? Is it not papillary? You know, should I call it? Well, now you know what to call it. It's a follicular adenoma with papillary architecture. All right. And they say that it is sometimes associated with subclinical hyperthyroidism, a hyperfunctioning nodule on a radionuclide scan. And it's a very challenging, obviously, fine needle aspiration specimen. I don't deny that, because there are always problems that will come up with any kind of technique. Okay. It is associated, they say, sometimes with activating TSHR mutations, and in a small percentage, this GNS or EZH mutations, which are often also seen in oncocytic tumors. But I just showed you this because this is what is coming out in 2022. And so now there is a continuum of risk, and I think we should get used to this and think of tumors which are follicular patterned. Okay, and now this is not only about encapsulated tumors. You have hyperplasia, non-neoplastic lesions, which, you know, I'm telling you, there is FND. Now they're calling it, you know, follicular nodular disease, or whatever is the name that they have come up with. There's a benign tumor. Of course, I have put all these things in there according to what I feel. There's a follicular adenoma. There's a borderline tumor, which they are calling, you know, umps of various kinds. And when you say a borderline tumor, you don't know. So is it invading the capsule or is it not invading the capsule? Can I see the follicular, papillary thyroid nuclei in a completely follicular pattern lesion? So then maybe you want to call it WT ump or an FT ump. And of course, I've put in red here, NIFTP. I do not believe that it is in this category. It should go here. It should be here as a follicular adenoma with papillary thyroid nuclei. But for better or worse, it is put into this low risk lesion. Then there are low risk cancers, which are minimally invasive follicular carcinoma. Also, I think the RAS mutated PTC, which is nothing but this follicular adenoma, which has got this papillary thyroid nuclei, or minimally invasive FTP, that is follicular tumor with papillary thyroid nu. Then you have moderate cancer risk, that is angioinvasive follicular carcinoma, widely invasive follicular carcinoma, and finally the high risk ones, which are anaplastic carcinoma or polydifferentiated thyroid carcinoma. Okay, so this is a way that you think about the continuum of risk. Now, I want to once again tell you that you have RAS mutated lesions and you have BRAF mutated lesions. BRAF, RET, NTRK, ALK fusions, whatever you want to see. Now, I want to look at the RAS mutated lesions, okay? These are all follicular patterned lesions. Follicular adenoma up to 20%. Follicular tumor of uncertain malignant, 20%. Well-differentiated tumor with uncertain malignant potential, 20%, okay? What is it telling you? It is telling you that these are all more or less follicular adenomas, okay? Up to 20% have been found. Look at NIFTP. up to 60% of NIFTP are RAS mutated. Are there any of them that are BRAF, RET, NTRK, ALK fusion related? And the answer is not found. And these are the mutations that are seen in papillary thyroid carcinoma. All right, so nothing. All right, let's go and look at the invasive, what they're calling invasive E, that is encapsulated follicular variant of papillary thyroid carcinoma. What does it have? 70% of RAS mutations. Go down the line and see, are there any BRAF, RET, NTRK, ALK fusions as seen in a papillary thyroid carcinoma? And the answer is not found. So why are we calling it the encapsulated follicular variant of papillary thyroid carcinoma? When it does not behave, does not have the molecular pattern and of papillary thyroid carcinoma, it merely has the appearance. And you have come to show, you know that you have now moved from this entity to NIFTP. So why are you now doing this with the invasive component when it is gone through just merely gone through the capsule and it is RAS mutated? Okay, so you know why now I have some bones to pick with this thing. So once again, I come now to my schema and my little blue box, and I have now no longer got EFVPTC because I had it at that time because I had no choice. There was no other name that I could have given it. But now I have NIFTP, and I would like to call something RAS mutated PTC or that's minimally invasive FTP, but all of them are encapsulated follicular pattern lesions of low clinical risk. Okay, so this is what I wanted to tell you. And what does this clinical risk mean? Once again, we are talking about risk. So what is this risk? Now, I don't want to go here. The risk is all about this. Should you do a lobectomy versus a total thyroidectomy? And let me just state it very clearly. If you have a tumor of low clinical risk, then a lobectomy is very much in order. If there is anything other than low clinical risk, then you will consider doing a total thyroidectomy. So what is this low clinical risk? Okay, now look here. This is how you do low clinical risk. Yeah, and this is for any differentiated thyroid carcinoma. So forget about UMPs. That means uncertain malignant potential and things that do not invade their capsule and all that sort of thing. Okay, so this is for proven differentiated thyroid carcinoma which has shown its invasive properties. Okay, so here you are. You first separate these patients out on the basis of age into those that are less than 55 and those that are greater than 55. Once upon a time, there was male and female in this because males seem to have a higher, or they thought that males had a higher propensity for more aggressive disease. But if you are basing this on the 8th edition of the AJCC, this is how risk is defined. Okay, so just look at this. You are staging. So all stage 1 disease is low clinical risk. I just want you to go through this, not because it has anything to do with our particular thing, but just see distant metastasis, and it is still called stage 2. Do you know any other tumor in the body where you have distant metastasis and it is still stage 2? Normally distant metastasis becomes stage 4. But if you have distant metastasis, and I'm not, now please don't think I'm talking about encapsulated lesions, but it has some bearing on that. Okay, so that is stage 2. The next thing that they do is, if you don't have to bother about extrathyroidal extension or whatever if this patient is below the age of 55. If the patient is above the age of 55, okay, you divide it into distant metastasis, yes or no. If it is distant metastasis, something that was stage 2 at the below the age of 55 becomes stage 4B if you are above the age of 55. Just look at that and be, you should, I think it is based on observations of how these differentiated thyroid tumors behave, okay? If there is gross extra, then if there are no distant metastasis, you ask, is there gross extrathyroidal extension? Gross, you can see the thyroid, not microscopic thyroid extension. If it is no, then you go into less than 4 centimeters and greater than 4 centimeters. If it is less than 4 centimeters, it is stage 1, okay, when you don't have any lymph node metastasis. Greater than 4 centimeters or, metastasis in the regional lymph nodes, then it is stage 2. And I don't want to get into the rest of it, but what I have boxed in blue is what we are talking about as encapsulated follicular patterned lesions, okay? Obviously, there will be no distant metastasis. Otherwise, who is going to even bother to find out whether it is invasive or not invasive? So it will be stage 1, and there is no question here of what is the size, okay? Then you come to those that are older than 55 and those without gross extrathyroidal extension, yes. If they are less than 4 centimeters, you call them stage 1, okay? And there is no, and I'm not even talking here about or about encapsulated lesions. It may be a papillary thyroid carcinoma that is invasive, or even a follicular carcinoma that is invasive, but it is less than 4 centimeters in size. It is stage 1. Now just imagine, it is not just encapsulated lesions, it is full-blown thyroid carcinomas that are less than 4 centimeters in size, that do not have distant metastasis, and you can get away with doing just a lobectomy. Lobectomy means one side of the thyroid, one lobe of the thyroid along with the isthmus. So you do not need to take out the entire thyroid. This is low risk disease. So what is the meaning of risk? Now listen carefully to what I'm saying. Risk is the risk of distant metastasis, okay? That is what it means. Now, if there is a risk for distant metastasis, you do not want to do anything less than a total thyroidectomy. Why? Not because you are expecting that disease will come back in that thyroid. It is because when that distant metastasis occurs, you do not want the rest of the thyroid gland to remain there, because the treatment of distant metastasis of differentiated thyroid carcinoma is by radioactive iodine. And if you have the thyroid in situ, which you will have if you have not done a total thyroidectomy, then that thyroid will act like a sump. That means you will have to give enormous doses of radioiodine, because that radioiodine will be picked up by that remaining thyroid. But if your risk of distant metastasis is very, very low, then why do you want to take out the rest of that thyroid? The patient will not have to go on thyroid replacement therapy for the rest of his or her life. And the chances that this patient will get a metastasis is really, really low. And this was what was true of that case where 14 years later, this patient developed a metastasis. Now, this was one of those rare cases where it was an encapsulated thyroid tumor, which had what I would have called angioinvasion. But even if it did have, I take that back again. It had capsular invasion, which I would have called capsular invasion. I mean, I haven't seen the rest of the case, but whatever was shown as possible angioinvasion, I don't think I would have agreed with it. So I would have called that a minimally invasive follicular carcinoma. And this is one of those rare minimally invasive follicular carcinomas that has 14 years later actually produced a distant metastasis. It is a rare case. So this patient lived with the rest of that. They didn't do a total thyroidectomy, and the patient was not on iodine, did not require iodine replacement therapy. Now, what would be the treatment for that particular case? Now the surgeons would have to go down, remove the rest of that thyroid. They are not going to find any tumor in the rest of that thyroid. Okay, that thyroid will be clean from any tumor, but they have to remove that part of the thyroid or the rest of that thyroid because they have to treat this sacral metastasis with radioactive iodine. And you can't have any thyroid in situ if you're going to use radioactive iodine, because that radioactive iodine is going to be absorbed by the thyroid, and you will just have to push up the doses of radioactive iodine to toxic levels. Okay, so that's what I wanted to tell you about. So it answers the question that we asked: what is the significance? And we now know the significance. The significance for any of these lesions, whether you call them invasive, capsulo-invasive, or you are, no, there's a hook, there is a this, there is a that, ultimately don't require anything but a lobectomy. Okay, so don't be too bothered about this. So the message that I'm giving you is, do not obsess over capsular invasion or nuclear features of an encapsulated, entirely follicular patterned lesion. Okay, so the operative words are encapsulated, non-invasive, non-angio-invasive, but if there is a bit of capsular invasion here or there, we are not going to worry about it because they are all follicular neoplasms of low clinical risk. Angio invasion is of great clinical significance, whether or not nuclear features of papillary thyroid carcinoma are present. Okay, so if there is angio invasion, that patient is not at low clinical risk. That patient will require the other part of the thyroid removed. And why should that other part of the thyroid be removed? Not because there is disease will come back in that thyroid. That's never the case, or very, very seldom the case. Okay, it's less than 10% that there will be some thyroid, tumor that is incubating in the other part, because whatever thyroid tumors incubate in that other part, and is usually multifocal PTCs, they never become clinically evident tumors. Okay, so you don't remove that other part of the thyroid for the reason that this lesion is going to come back in that thyroid. You do it because you are expecting distant metastasis. The risk of distant metastasis is high. And in such a case, when that distant metastasis, if and when it occurs, you don't want that thyroid tissue in situ. Okay? You can always go down later and take it out, but it's not easy to go in and take out a thyroid which has has scarring and other things because somebody has interfered with the thyroid in before. Okay, so I think that this is the real message, and you must have a rapport with your clinicians, and it is especially important in the era of risk adaptive therapy. So I think that's the end of my talk. Let me sort of shut down and stop sharing my screen, and I will take any questions if there are any questions.
Yes, ma'am, there are some questions.
Good.
Ma'am, Dr. Babita Sodhi has asked, can partial invasion be called as minimally invasive carcinoma?
Babita, have you been listening to my talk? Okay, there is no such thing as partial invasion. Okay, if you want to call something according to the strict definitions of invasion of the capsule, then it has to be full thickness invasion, right? Now, there are many things that I have shown you which some experts will consider invasion. And certainly, if there is a hook-like invasion, I'm one of these people, I won't call myself an expert, that I will consider invasion, and then I will not call it partial invasion, I will call it invasion of the capsule. Okay, but if you want to go by definitions, then the definition is full thickness invasion of the thyroid. Okay, so I hope that is very clear. You can make up your mind whether you want to beat about the bush and you want to say that there is invasion of the thyroid and it is not full thickness invasion. But make up your mind whether you want to call it invasion or you don't want to call it invasion, knowing fully well, Babita, that this is a tumor of low clinical risk. And if you are in rapport, you have a rapport with your clinician, then that patient does not require a total thyroidectomy. That is what I want all of you to understand. It may be a little too difficult for postgraduates to take it in because they are only concerned, how will I report this if it appears in the exam? Okay. When it appears in the exam, you need to know if you're writing an answer to a paper or you are asked about it in your viva, or you get a case which you have to diagnose. Unless there is full thickness invasion, please do not call that a follicular, carcinoma. In which case, you will have to just say that it is not full thickness invasion. But I am talking to you people who are in the hot seat every day, and sooner or later, postgraduates are going to be in a hot seat. Okay, you have to make decisions. So just understand that if you are not convinced that there is invasion, say there is no invasion. Don't worry about it. It just means that this patient has got low clinical risk. They will do a lobectomy, and like that particular case, maybe 14, 15, 18 years down the line, there may be a metastasis. But if you are in rapport with have a rapport with your clinician is not going to come back and say, oh, you said this, because he will know, he has every, so he will know why he took that decision, and you should also know why you advised him that this particular thyroid neoplasm, which was encapsulated, should not have been treated necessarily by, if he's old-fashioned, by removing the rest of the thyroid. If he's old-fashioned, if he sees the word carcinoma over there, he's going to take out the other half. So, sometimes as you get older, you write reports that suit your clinicians. In the suit meaning, you don't want them to do something, you use some other terminology, okay? So, Babita, please, I hope that you have got the message. All right.
Another question is from Dr. Nishat Afroz. For angio invasion to be significant, isn't the single vessel invasion sufficient for aggressive treatment? Or
the answer is yes.
More foci?
As far as I'm concerned, the answer is yes. Angio invasion, I know that there was, but as of now, it's enough to have angio invasion, that you don't wait to call this a minimally invasive thing. A lobectomy is not sufficient for a tumor with angio invasion. Okay.
Dr. John O'Malley has asked, for the equivocal cases, would you call it atypical adenomatous nodule and then request for HbME1?
HbME1. HbME1 is not a particularly good marker of anything. Okay, so I don't use any diagnostic immunohistochemistry for thyroid neoplasms, not at all. Okay, so no, I would not do that. If you're wanting to do anything that is of any clinical value, and it is impossible to do that in most clinical situations, certainly the clinical situation in which I work, you will have to ask whether you should do RAS mutations or RET PTC, RET or BRAF mutations. No, nobody is. I don't think that HbME1 has much value at all.
Ma'am, Dr. Vanessa Sebastian has asked that without taking out the thyroid, how can we say encapsulation, angio invasion, etc.? So will it always become a two-step surgery, lobectomy, later total thyroidectomy?
Sorry, can you repeat that again? Because I was,
Yes, ma'am. Dr. Vanessa has asked that without taking out the thyroid, how can we say encapsulation or angio invasion, etc.?
no, you
will
have
it-
to know, my whole talk is not on FNAC. Okay, my talk is based on at least a lobectomy. Okay, meaning that you have got the tumor resected. This is not something that you can do on FNAC. This is not something that you can even do accurately on this frozen section. Okay, because how many sections of the capsule can you take on frozen section? How easy is it for you to see whether there is angio invasion on frozen sections? You can't. What do we do frozen sections for on the thyroid? Okay, I'm not a great proponent of frozen sections on the thyroid, but yes, if there is a nodule and you don't even know whether this thing is a follicular carcinoma or not, sometimes you can, the nodule which is unencapsulated shows you a very frank papillary carcinoma, which is fine. And I'm not meaning encapsulated follicular variant of papillary thyroid carcinoma, just a frank papillary thyroid carcinoma, in which case the surgeon will make a decision then if he's got a 5 centimeter nodule or the patient is 55 years old or above, then he may want to do a total thyroidectomy. But by and large, I am not a great proponent of trying to evaluate the thyroid capsule on frozen section. Okay.
Okay, ma'am. Dr. Kumuda has asked that nodules in thyroid are common in India. So any molecular studies are done, please share your thoughts.
Molecular studies are done in India? Is she asking about in
Yes,
India?
ma'am. She's asking if any molecular studies.
No, I don't think, molecular studies are really done in India. I think that there is data that is being collected on papillary thyroid carcinoma and BRAF for the simple reason that, and this has got nothing to do with encapsulated follicular variants, I'm just talking in general, that BRAF is considered to be, and we do not have absolute data on it, one of the factors that makes a thyroid tumor, papillary thyroid tumor, relatively resistant to radioiodine. Okay, that is, it has not been proven 100%, but in a lot of places abroad, molecular studies are used as an adjunct to FNAC. So you have a solitary thyroid nodule. You want to know whether this is a papillary thyroid carcinoma, or this is a RAS mutated tumor, or sometimes even an encapsulated medullary carcinoma. That means not encapsulated, but you can get your sort of molecular studies done. But you know how much it costs? It costs upward of, if you just want one molecular study and that is just a simple BRAF, it'll cost you $1,500. If you want all of the things, it'll come to about $6,000. Okay, so I don't think that anybody's doing it, but many institutions, like for instance Tata Memorial Hospital, did do a study, and I think that was published, if I'm not mistaken. Dr. Kane was one of the leads in that study as to what is our BRAF incidence in papillary thyroid carcinoma. So if you're doing a study, yes. Otherwise, I think unnecessary.
Okay, thank you, ma'am. Ma'am, I also have a question that, ma'am, what should be the management in cases of multifocal encapsulated follicular variants of papillary carcinoma? Because you showed a case in which there was metastasis after many years. So what should be the management in multifocal cases?
Multifocal, where do you get multifocal papillary thyroid carcinomas? You don't, as a rule. You get multifocal follicular adenomas. Yes, that is a very common thing. And now I told you, they've got this FND or whatever term that you may want to use, follicular nodular disease or something in the thyroid. I don't even remember it. But to any one of those nodules, if there are multiple nodules, I have never seen follicular carcinoma, minimally invasive or widely invasive, associated with multiple thyroid adenomas. No, it doesn't happen. So it's usually one. But your question, you had a second corollary to your question, which was something else. How can we be certain that this something will not metastasize? I don't think anybody can be certain that something will not metastasize. You just have to work on probabilities. Now, I will ask you, every time we report an amyloblastoma or we report a giant cell tumor of bone, okay? Are you sure that it will not metastasize? No, because we know that there is a metastatic, metastases have been reported, and every now and then, if you are in a high throughput center, you will see, amyloblastoma, which after 14 years, 15 years, 16 years has metastasized to the, to the lung, or a giant cell tumor has metastasized to the lung. Should we therefore treat all amyloblastomas and all giant cell tumors as if, they were going to metastasize and do horrendous surgeries for them? No, I don't think so. So this is what we have to understand. What is of low clinical risk and what is of more than low clinical risk, maybe intermediate or even high clinical risk, and then act accordingly. And all patients should understand that this is they have to be counseled as to why they're having a lobectomy, and why, even though that they have so don't even talk about encapsulated lesions. I'm talking about frank papillary thyroid carcinomas that are less than 4 centimeters in size. Frank, invasive, papillary thyroid carcinomas of usual type, and nobody is taking out the other part of the thyroid. Now, they have more than just a minimal invasive, but they are still tumors, stage 1 of low clinical risk. Okay.
Okay, thank you, ma'am. Another question is from Dr. Sonal Gupta. She's asking, what should be the management of non-invasive encapsulated papillary RAS-like tumor, thyroid tumor?
Lobectomy, like any other tumor. Why should it be any different? We are just calling this RAS and calling it with papillary thyroid nuclei. I told you, no, if it were left to me, I would call it a follicular adenoma because it's non-invasive. Why are we calling it this? You have to ask the people who write these things. If you want me to say it, I'll say it openly. It is because nobody wants litigation. Do you realize that there are thousands and thousands of patients who have had NIFTP, what we are calling NIFTP now, which we called EFVPTC before? Okay, their thyroids have been removed. Most of them are on long-term thyroxine therapy. Now, if somebody comes up and calls this a follicular adenoma, do you not see in a litigious society like in America that they are going to, so they are calling it of uncertain, that means there you are, it's a tumor, we don't know that it is an adenoma, and they are putting it as low clinical risk. Oh, listen to me, that there is more to diagnosis than just morphology and molecular and everything. There is politics in diagnosis, and if you don't know it now, you will live in an idealized world. Okay.
Okay, ma'am, we have a very interesting question from Dr. Bala, that if papillary carcinoma could be seen as incidental finding and with excellent prognosis, is it a real malignancy?
Well, what's a real malignancy? I would like to ask Bala, how does he define a real malignancy? Okay. Everything has got risk attached to it, right? When I say that something is a follicular adenoma, I'm saying this on the basis of my 5, 6, 8 sections that I might have taken. Yes. When I say that something is got a clean margin, how can Bala tell me that there is no margin that is not being invaded and I haven't seen it? So that is one aspect of this of this question. Okay. The second aspect of this question is just because an incidental tumor has not metastasized, and Bala, I mentioned it, perhaps you didn't catch it, that the reason for removing the other part of the thyroid is not because there may be some incidental small tumors over there which will grow. Okay, and in every papillary thyroid carcinoma, there is a 50% chance that there will be some small multiple foci in the other lobe. And yet, with a full-blown invasive papillary carcinoma that is smaller than 4 centimeters in size, we do not, the risk adapted therapy suggests that the other lobe not be removed, when I know that 50% of patients will have another small lesion in the other lobe. So can Bala tell me why that doesn't grow? It doesn't grow because it just has, every tumor does not have the same growth potential. At the moment, sitting over here and you, Bala, sitting over there, somewhere in your body, you have some rogue cells, okay? But they are not growing. So does that mean that when you have a full-blown carcinoma, that it is, because it is related to something that doesn't grow, that it is not a carcinoma? No, Bala, please. Okay, we have to have a little bit of, what shall I say, common sense about this.
Ma'am, Dr. Mohan has asked, is optically clear nuclei a must for diagnosis of papillary carcinoma or papillary architecture sufficient?
Repeat that question, sorry.
Is optically clear nuclei a must for diagnosis of a papillary carcinoma or papillary architecture is sufficient?
That's an extremely valid question. Yes, by and large, you do need, this. But if you have got a frankly papillary architecture, okay, and there is no other name for it. Now, if you look in the new classification, this cribriform modular variant of papillary thyroid carcinoma, which was, okay, has been removed out of that because its molecular pathology is completely different. But columnar cell the columnar cell variant, yes, not the tall cell variant. I'm talking about the columnar cell variant, which actually, for all practical purposes, looks like a tumor that you would see in the gut, in the colon. It's got papillary architecture. It does not have the papillary thyroid nuclei, but it's a papillary carcinoma. So I would say common sense once again trumps everything.
Ma'am, Dr. Sushma has asked, is BRAF mutation analysis done for every case in Tata Hospital?
No.
What's the importance of it?
The answer is no. Anyway, I'm not in Tata Hospital, but it is not done in Tata Hospital.
Ma'am, Dr. Sindhu has asked, can a NIFT-P be multiple?
NIFT-P be multiple? I have not seen it as multiple, but if it is part of this follicular nodular, sort of disease, I don't see any reason why it cannot be. It's a RAS mutated lesion. So it may be. And again, as I told you, it depends on your definition of NIFT-P. Okay? This NIFT-P, if you will accept anything as being, clearing of the nuclei, yes, then you will see very many more multiple lesions. But if you are strict about your definition, then you are unlikely to see many. Okay?
Okay, ma'am, Dr. Nidhi has asked, is every capsulated follicular pattern lesion a follicular adenoma if no capsule or vessel invasion? Can it be adenomatous nodule?
Yeah, again, sorry, what was the name of the person who asked the question?
Dr. Nidhi.
Nidhi. As I said, I don't care. Okay, because there is absolutely no reason to even try and make the distinction between an adenoma and a dysfunctional thyroid nodule. Okay, if this adenoma has got a thin capsule and there is no even evidence of anything trying to make its way outside of that capsule, what does it matter whether you call it a follicular adenoma or a dysfunctional nodule? Okay, there are definitions. Follow the definitions. If you see more than one follicular adenoma in a multinodular goiter, I report it. But if you want to call it a multinodular goiter, I have no objections, and nobody should have an objection. But make sure that this lesion does not have a thick capsule. Number two, you have studied enough of those the capsule to make certain that there is no invasion in that capsule. Okay. Otherwise, the distinction is completely clinically irrelevant.
Okay. Another question is there. The name is not mentioned here, but the person is asking, in clinical practice, can't we just give report out low risk follicular pattern lesion as just follicular adenoma, just for the significance purpose?
No, I don't think that is, it's like diagnosing leukoplakia. Okay, leukopenia is not a pathology diagnosis. The diagnosis, what you see in leukopenia is a keratinizing lesion. So it is a keratosis with or without dysplasia. That is what we should be calling something that the clinician sees as leukopenia. So high and low clinical risk is understood by your pathology diagnosis. Okay, so don't try to, sort of straddle the fence by saying, oh, I called it as low clinical risk. No, because there are many things that are taken into account for clinical risk. And I told you that the first thing that is taken into account is the age. All right. Age is of importance. Whether or not there is distant metastasis is important. Many things are important. Okay. So you cannot be the arbiter of what is low or high clinical risk. You can have a good idea as to whether what you are going to report will be considered as low or high clinical risk, but please don't do it. Just report what you see. Don't do this, because I think that you are then entering into very, very treacherous therapy. Don't try to tell a clinician what he should or should not do.
Okay, ma'am. Thank you so much, ma'am. That was the last question.
Oh, it was the last question. Thank you. Thank you, all of you, for a very patient hearing. I hope that I made some things very clear, but I just want to leave you with this last message.